Thank you, Dr. Schulman. I'd like to thank you for inviting me here and for having the press here to talk about our study that we presented yesterday. Dr. Schulman has given actually a good background on the question, and I'd also like to thank Dr. Schulman as actually being the site investigator for the site that enrolled the most patients into the study that I'm going to be talking about. So he's a very active investigator, as well as being the leadership of the society and the president of the meeting here this year. Our study also looked at patients with atrial fibrillation, and as you've heard, patients with atrial fibrillation are the most common population that is being treated with some type of anticoagulant or blood thinner in order to prevent stroke or other arterial clots or emboli. The most commonly used medication in these patients continues to be Warfarin, which has been around for decades. The situation with Warfarin is that when you stop the Warfarin, it may take 5 to 7 days before it's completely out of your system. When you start it back up, it may take 5 to 7 days before it's actually working again for you. So it's a longer acting drug. People have been concerned that when patients need to have surgical procedures, they would therefore have 10 days to 2 weeks or so where they're not on a blood thinner, and therefore they would have an increased risk of stroke. So what people have done, as Dr. Schulman described, is they've used a short-acting shot, a form of a heparin called low molecular weight heparin, that they could administer in that perioperative setting to try to decrease the risk of stroke. Now, it's always been recognized that the trade-off is that you potentially increase the risk of bleeding by doing that, by having somebody fully anticoagulated right up to the time they're going to have surgery and then restarting that right afterwards. But there had never been any prospective randomized trials investigating this question. All guidelines and recommendations were based on cohort studies or registry studies, so we had no good data to make recommendations. And therefore, you would see providers do different things for their patients. The BRIDGE trial was funded by the National Heart, Lung, Blood Institute of the National Institutes of Health in the United States. It was conducted in the US and Canada. We enrolled patients with atrial fibrillation who needed to have a surgical procedure. It had to be an elective procedure, so it was scheduled. And those patients were enrolled in the study, and then they were randomized to stop the Coumadin that they were on, or the Warfarin, 5 days before surgery. And they were randomized to either go on full active low molecular weight heparin shots or a placebo shot. And then what we did was we managed the patients in the perioperative setting with our main question being, was placebo not inferior to or as good as using bridging? That's what we wanted to study. We enrolled patients and then followed them for up to 30 days after the procedure. In addition, after the procedure, the patients who were randomized to the bridging arm used the low molecular weight heparin while they restarted their Warfarin. The patients on the placebo arm just restarted Warfarin. We enrolled a total of 1,884 patients into the trial, and that gave us 1,884 patients into the trial, and randomized to both arms. All of the patients, actually, we had a very good completion rate of the study. Over 90% of patients, over 95% completed the study. And what we ended up finding was that whether you took placebo or whether you took low molecular weight heparin, the risk of a stroke in that perioperative setting, defined as up to 30 days after surgery, was less than 0.5%. There was no improvement in the patients who took the low molecular weight heparin over the placebo. So in other words, just simply stopping Warfarin, letting it come out of your system, having your procedure, and then going back on Warfarin was not inferior to using an aggressive strategy to anticoagulate with a low molecular weight heparin. At the same time, what we found was that those patients who took the low molecular weight heparin had about a 2 to 3-fold increased risk of major bleeding. So not only were we not giving the patients any protection from arterial thromboembolism, we were exposing them to potentially increased bleeding risk in that perioperative setting. We had several limitations to the study that we needed to address, one being that our study did not look at patients with prosthetic heart valves like mitral valves or metal valves, so you can't extrapolate our study to that patient population. We also didn't look at patients with venous clots like deep vein thrombosis or pulmonary embolism. Our study was entirely atrial fibrillation. We did have some patients in the highest risk categories of atrial fibrillation, but relatively small numbers. But we would estimate that the vast majority of atrial fibrillation patients, based on our study, do not need to do anything when they stop warfarin prior to a surgery and then simply restart warfarin afterwards.